Hey guys, welcome back to the Foam Frat podcast. We're talking about intranasal medication delivery this week. I just put out a blog yesterday and I went through my initial experience with intranasal fentanyl. And I can remember to this day, we got it. We got those little mucosal atomizing devices, those little look like little hats, little white hats. And you would put that on the syringe and then you would push the medication into their nose and you didn't have to have an IV. And I remember thinking, well, I'll just get an IV, but we had a ski hill. You remember Little Swiss ski hill? We used to go there all the time.
For the
And
same thing every time.
same thing every time. Somebody get wild, they get gutsy, and they crash into a tree or something. And so you would get there and you'd be down in like the ski patrol room and you would hear them talking on the radio and stuff. And they would bring the patient down on like a sled behind a snowmobile, or sometimes it would just be a guy holding on to something and skiing down. It was terrifying. And they would get him down there and then they'd be like freaking out. Like not all the time, but the one that I really remember, this guy was like screaming to just put him out. And I looked, and you can imagine they have all of this equipment on, these big jackets and these snow pants and boots and stuff, and getting them to where you could actually start an IV or being able to actually get their coat off or their pants off without them screaming was actually like a super hard thing to do. It was a huge challenge. And so I remember thinking when we got that intranasal delivery device and we heard the different drugs that we could give intranasal, the one that stood out was fentanyl. And so I go through the story of me telling this guy, hey, you know what, pal, I'm going to take care of you. I'm the candy man here. I'm going to give you something that's going to make you feel real good. And I draw up my IV dose of fentanyl. I was going to give him 1 mic per kilo. I think I was giving him like 100 mics or something. And I scored it in and I'm sitting there going, any second it's going to kick in. And the guy's looking at me like I just gave him a placebo, right? He's like waiting and waiting and waiting and nothing and nothing. And I'm just sitting there staring at him and nothing. And I'm like, all right, you feeling any pain relief? He's like, no, not at all. It's actually hurting worse now. And so I was like, God, I kept seeing this trend where it was not working on adults. Have you ever seen that before? What's been your experience?
Yeah, so I haven't tried it on a lot of adults, but I had a near adult size pediatric. I don't remember how old she was. It was some years ago, but she had an angulated, not a fracture. Her knee joint was just completely dislocated, and her patella, like it was all swollen. We couldn't even find it. Like it was just a really bad twist accident, and she was like stuck in the position that she was in. And so I was like, it was like one of those situations where it's like somebody's holding onto her shoulder and she's holding her leg, and any tiny movement is sending her through the roof. And I was like, I want to try that intranasal fentanyl this time, and it seems like a good time to do that. There's like people around. I won't have to bother with the needle. I think that was one of the first times that I tried it. And essentially the exact same experience that you had. And it was even awkward because people are like holding on to this person because she doesn't want to lay down and she doesn't want to move. And so she's like all her weight's on one leg because the other one is like injured, And so it was this super awkward situation where it's like, I think everybody was expecting this medication to kick in, and then we just calmly lay her on the cot, and she's like, but no, it was just a total failure, and she was incredibly uncomfortable. And we ended up going for intramuscular after that. It didn't. I abandoned it, and I haven't come back to it too frequently, except for some very odd circumstances. But yeah, never had much success with it, especially in like adult larger patients.
Yeah, there's certainly circumstances where you need to take care of someone's pain in order to do a better assessment. And getting an IV is just not feasible. I had a patient who was in a 4-wheeler accident not too long ago, and they were covered in mud in a field. And I'm like, and they're screaming in pain. And I'm like, God, to start an IV right here, I got to clean this off. It would be so dirty to do that. I need to get them to a place where I can clean them. And so I thought, I could do intranasal fentanyl. It just didn't work right. And here's why. Here's the problem. This is what I came to realize. I was listening to the Pediatric Emergency Playbook podcast. Like, I don't know, this had to have been over 10 years ago, maybe. I think maybe 8 years ago. And they mentioned that you have to double to triple the IV dose when you give it intranasally. And that's probably because some of it is just going to go down in the throat, right? So you have
Mhm.
a surface area, you're trying to get that on, but you're also shooting it into a void that does go down in the throat. And just like
Mhm.
any other medication that you spray in your nose, some of it is not going to get absorbed.
Mhm.
And so that made a lot of sense. I'm like, okay, I just wasn't giving enough. But the problem is you're only supposed to give like 1 ml per nair.
Mhm.
And so if you double to triple the dose in adults, you have to do a few transactions, you're going back and forth,
Mhm.
and it's just not effective. It doesn't work too well, which is why when you look at the literature, it's a lot of pediatric literature for maybe
Mhm.
procedural sedation, for analgesia, and that's really where it shines because you can double to triple the dose and still fit it in that 1 ml per nair. And so that was like a game changer. It was like, okay, intranasal medication for me meant that for at least for pain management, I know people do like Narcan and stuff up the nose, but for pain management, that meant that was probably going to be a pediatric thing for me. And maybe I would just go IM or something if I had to do it in an adult. So that was like the big game changer for me in my head, or my shift in my mental model was I'm not going to grab that atomizing device when it comes to an adult and pain management.
Yeah, you mentioned the naloxone. I wrote down some of the medications that you can give because there's a few that are easy to remember. Like everybody knows you can give naloxone because it's probably the most common, fentanyl, midazolam. But there's a few other ones I wrote down. I made a list because there's one I didn't think of too often. Lidocaine, we never really give intranasal for any reason, so I kind of just like scratched that one off. But glucagon and dexmedetomidine were the other ones. I've never heard of dexmed being given. Oh, and I think one source said haloperidol as well, but I'll double check on that. I don't know why I
Oh,
didn't put it on my
interesting.
list, but Dexmed, haloperidol, and then glucagon can be given that way. I don't know why you'd give it or not intramuscular, but anyway, those are just the medications that can. I remember seeing one source, and I think maybe somebody can correct me on this because I haven't seen it ever since. They said you could give Ativan intranasal. And I was thinking that stuff is like so oily and
I've
thick.
heard that before too.
But
Yeah.
it's you'd think that it's like way too thick to you know what I'm saying? It's like all oily in the syringe
To
in the vial.
absorb into the yeah.
Yeah. So
Yeah,
speaking
I
about that
remember when we
absorption. Oh, what was that?
no, I was just gonna say when we worked at Lifestar, we we were told not to give Ativan just because of like you said, it's very oily and it just probably wouldn't absorb good or wouldn't atomize well either. Go ahead. What
Yeah.
were you saying?
As you had some references in the blog about where to aim this thing, and I wish I would have. We'll have to do this for the course and take some pictures. Everybody's listening to the audio podcast won't be able to see this, but I got this little handy guy here for those of you who are
Oh
watching the
yeah.
YouTube version of this. And then I grabbed the old neosynephrine spray right here. so, so this would be aiming up towards pretty much their eyeballs is it just goes straight up, right? And
Right.
so you're not hitting those turbinates in there, right? So how far do I go back like this? Like where should the tip of the atomizer be aiming?
So you want to aim the tip towards the top of their ear. So they call it
Okay.
like the helix of the ear.
Oh, well, I got his ear right here.
Man, you planned this all out. Yeah, you want to aim up there because that's going to get you in that area where the turbinates are, the turbinators. And what you want to do is aim there, and then the other thing is it naturally you want to tell them to sniff, right? Like take a big
Mhm.
sniff, but sniffing is an inspiratory move that is going to draw that back down into the throat. So don't have
Yeah.
them sniff. That's going to move it down to the throat. You want to just let that sit in that area. What's interesting though is sometimes you'll hear people talk about it bypassing first pass metabolism. And there's that little cribriform penetration right at the top, like right as you go into that nasal vestibule. There's that little area where the cranial nerve 1 actually penetrates the cribriform and goes right into the nose. And that's why you can smell things and interpret them so quickly because you have that there. Some of that drug could actually get in there and go bypass the blood-brain barrier and get right to the brain. So that's kind of cool too. I don't know if you could really aim for that spot. That's not where the largest surface area is. The largest surface area is in what they call the respiratory region, which is those turbinates. And that's just like those bony structures covered in that mucosal lining. That's where a lot of that is going to is going to actually absorb, is in that area. I read one source that was saying that you shouldn't have them like sit up. You should like put them almost in like the I want to say like the sniffing position, but have them lay back so that way it doesn't run down their throat and it sits inside the nose, and that would benefit as well.
Oh, interesting. Yeah. So so those turbinates are kind of like straight back, and that's one thing I learned from. I remember looking at anatomy for the first time because I would always use this kind of stuff, like the neosinephrine. Whenever you have a stuffy nose or something like that, you
Yeah.
kind of like gauge it on yourself, like where you should aim it, and then you look at a piece of anatomy like this, and you're like, man, do those turbinates are way lower than I thought. If you don't look at something like that, you kind of think your nasal passages just go like straight up. But
Hmm.
I guess you also learn that when you start putting nasal airways in people, how it just kind of goes straight back. And I always remember like thinking that was surprising because I like the first time I put a nasal airway in, I really expected it to go up, but it kind of just went straight back. And I was like, maybe the nose, the nares aren't shaped like I think they are. And so, but I think a little bit of that carries over when you give an intranasal medication that, yeah, you need to aim it kind of far back. And it's cool to take an atomizer too, if you have one laying around the station, and just spray it, without anything around it, and just watch the dispersion of it, because it's not like there's nothing on the tip, and it's like you're shooting a flush across the room. This thing is dispersing it in a pretty wide cone. And so you are still getting up to that olfactory interface of that cribriform plate, even when you're aiming it pretty much straight back, or a little bit less than straight back. So you're still hitting the majority of those turbinates, but you're also hitting that cribriform plate. So that's probably the best dispersion. I like that aim for the top of the ear thing.
The other thing is that if you push it, you don't want to push it slow because that can actually cause like droplets, and you want it to atomize. And so I notice sometimes people will push it a little bit slower. You want to really cram that in. And then if you have to in a kid, if you need to give like, if it requires 2 mLs, I wouldn't do this side and then do this side. I would just double barrel it and go both sides at once. So that way you only have to do it one time, because they're probably going to shy away
Mm.
from it. And some of the other resources say to not approach the kid from the front with it. You can imagine that'd be terrifying. So you want to come in from the sides when you administer that. And so that way they don't see it and think you're giving them a shot or something.
I'm picturing the kid kind of like you behind the cot, and you've essentially got it like this, and you come from behind, and you're like in the nose like this, sneaking from behind. But yeah, okay, so yeah, speaking of kind of the volumes in there and stuff, so you're talking about volume. So it's usually 0.5 to 1, and I guess you just kind of gauge that. I've never seen an age recommendation where it's like, oh, the max for this tiny little kid is 0.5 and the max for this kid is 1. So yeah, the range is always like 0.5 to 1. But you mentioned in the blog too, which is a good point, that there's some dead space in the end of that atomizer. It's about 0.1 ml, so you got to drop a little bit more medication. And I don't know if you were taught this too, but I was always taught to draw back the syringe a little bit further too, so that there's some air in the tip before you start pressing, so that, like what you were just saying, you can like get up to speed.
Yeah.
It's like your takeoff zone. Like you're getting it up to speed. That air rushes out of the end of it, and then by the time that that's doing, the plunger's moving fast enough to where as soon as the medication hits the atomizer, it's dispersing pretty well. Were you taught the same thing
Yeah,
about that?
same thing. Drop a little bit of air in there, so that way and I mean, you're not putting it in a vein, so it doesn't matter. But that way you can get up to speed, because that initial push is probably going to be a little bit slower than the rest of it, and that could form those droplets, which aren't going to do anything.
Especially when you're sneaking up on that kid from behind.
Coming around them with both sides.
Yeah. Yeah. So speaking of these kids with the pain dose stuff, so there was one study that you were mentioning there where they looked at, what was it? It was fentanyl at how many mics, and then they also looked at ketamine, or no, was it just the ketamine at 0.75 for pain as well?
Yeah, so they looked at ketamine 0.75 milligrams per kilo, which is 3 times the IV pain dose,
Mhm.
and then they looked at fentanyl as well. And they didn't really see a big difference between the two of those. And then you sound like you saw one that was similar, a non-inferiority trial.
Yeah, that was the Prime trial. I think it was in 2009. I don't have it right in front of me, but they did something really similar, except they used a way higher dose of ketamine. They used 1.5 milligrams per kilogram intranasal, and the fentanyl was, I think it was 2 mics per kilo intranasal. So it compared intranasal to intranasal, and then it was just looking to see if, so fentanyl was like the standard, and then they were just seeing if ketamine was non-inferior to that, which it was non-inferior according to their standards. But that was in, kids that were smaller, so that was well, no, there could have been some larger ones. I didn't look at their dispersion, but 8 years old to 17 years old, I think. So there still could have been some larger kids in there, but that is a pretty big dose of ketamine, especially if they're just going for reduction of pain. I was thinking about that too with the naloxone that you were talking about in the blog as well, because people are like, well, the naloxone works so well when it's intranasal, but a lot of the patients that you give it to could probably get by with zero point 0.4 milligrams or even 0.2 milligrams sometimes. Like sometimes they don't even require that large of a dose. So if you're given every,
IV.
yeah, or intranasal, 0.4 to 2, like if you're
Yeah.
given, let's say you're given 2 milligrams, intranasal, so you're given, the whole thing intranasal, those patients sometimes could get by with a pretty small dose. So let's say they could have gotten by with like zero point 0.4. If you're given 2 milligrams, that's 5 times the dose right there. So that, or if you have,
Yeah.
4 milligrams, that's still a pretty hefty dose. That's probably why it works, usually pretty well, is because it probably is a lot more than the dose that you actually need.
Oh yeah, absolutely. They the ones I was looking at were like 6 and 8 milligrams per spray. So it
Whoa.
makes up for any bad technique, like you're just flogging them with those things, and I'd be
Yeah,
banging, bringing them back.
yeah, that's a ton. So yeah, no wonder, because I think that people kind of hold that to the standard because that's the most common kind of intranasal
Yeah.
medication. So I think they see that and they're like, man, that works so well. Why is it so hit or miss with these other medications we give it intranasal? It's probably because we just give a lot of naloxone, but with other stuff, we generally don't give as much. I think that's probably the reason. The other thing I was thinking about with dispersion too, when you were talking about it before, was that the nose is kind of like intranasal is kind of like rectal administration, where you kind of
Yeah.
have these foreign
Where are you
bodies.
going with this?
You kind of have these foreign bodies in there, is what I'm saying. Like you'd, in your nose, you could have like,
Well, sometimes they're in there and sometimes they're out.
yeah, yeah, exactly,
What's
right.
the
So
foreign body? The turd?
yeah,
Oh, all right. I
well,
don't know where you're going with this.
yeah, I don't know where you're going with that, but the either you got boogers in the nose or you got turds in the rectum. So that all is going to play a role.
Thank you guys
That all is going to
for
play a
stopping
role with
by.
that all is going to play a role with the absorption of the medication. And I almost think like with kids, if you're going to give them a certain type of medication, kids are always, I have this like picture of kids, the hands are always sticky and they're always snotting and a bunch, and so to me, like you'd always have to suction the nose, get all the snot out of there first, but probably
That's
only
true. You do,
required
yeah.
very occasionally.
Or if somebody snorts cocaine, it's not going to work either. They're going to be all
Oh yeah, no,
destroyed.
it's all vasoconstricted up there. Do you think the
I've heard of
same thing is true
atomized.
for?
Go ahead. What?
Do you think the same thing is true for like a neosynephrine spray? Do you think that would reduce the absorption of the medication if it was, because this vasoconstricts as well?
Yeah, probably. I've also heard of people nebulizing and atomizing TXA, which I
Yeah,
don't know how well the absorption would be, but I thought that was interesting as well.
yeah. You know what? Well, I don't remember what we did on TXA. I can't remember what I was doing, but I remember telling Kristen about it, my wife, who's a respiratory therapist, and I was like, "Yeah, this dose that I'm looking into. I think I was reading like one of the crash studies or something like that, and she's like, what are they giving it for?" And I was like, severe trauma, multi-system trauma or whatever I was reading about. And she's like, "Oh, they give it for that?" I'm like, "Well, what do you think they give it for?" She's like, "We nebulize that stuff all the time for like, epistaxis,
Tonsils.
nosebleed, hemoptysis and stuff like that." And she's like, "That's really the only reason that I handle it. I didn't know that they were given that in like traumatic arrests, or not traumatic, but traumatic incidents and stuff like that." And so that was interesting. But yeah, so they do that quite a bit. I'm not sure what the efficacy is. I've never nebulized it for those reasons, but I know that there have been some studies on that before. So I know that they still do it.
Well, cool, man. Awesome. If you guys have any questions or you found any tips or tricks, let us know. Shoot us an email, team@foamfrat.com. As always, this episode is brought to you by the Foam Frat library, which is it's our course. It's a ton of hours, over 150 hours, live classes Monday through Friday, 3 times a day, twice on Friday, all CAPC accredited. So we would love to see you in our live classes and hang out with you. So you got anything else, man?
No, I think that was it. Great blog. I really enjoyed that. And the medication administration stuff can be there's some real nuance to it that you can forget about until it's time to do it. And this is a good refresher. So nice job.
Awesome.